First of all, I would like to thank Vibhuti sir and AIOS Scientific Committee for giving me this opportunity. So I'll be highlighting some important point, how to interpret specular microscopy and what are its clinical implications. So I have no financial interest. Specular microscopy is a very practical tool not only for the corneal surgeon but for all ophthalmic surgeon in identifying the subtle changes as well as the macroscopic endothelial changes prior to any kind of ocular surgeries. So we routinely do this test on all the patients, nearly all the patient in OPDs, but the problem is we cannot keep the record, we cannot document these findings for the monitoring of patients. So specular microscopy is a non-invasive modality which can document the healthy as well as diseased endothelium photographically. And with this test, you can monitor the patients. What types do we have? We have clinical setting specular microscope as well as eye bank settings. In clinical settings, we have two type of specular microscopes, non-contact and contact. In non-contact specular microscopy, these things are very quick. We can get the quick results. Anybody can do for it. But it gives less magnification and resolution in comparison to the contact one. Because the contact specular microscopes use they applanate a larger surface of cornea to get the good results. So irrespective of the type of specular microscope, the optical principle will be same, that is specular reflection. So as we know that if the light falls on any surface, it may get transmitted or part of it light absorbed and part of it get reflected. So what the specular microscopy does, it actually catches the light which is coming from the endothelial and aqueous interface and then gives the picture of endothelial image. So what are the methods of analysis? There is automated method of analysis which is present in non-contact specular microscope, and here machine itself trace the cell borders and take it for analysis. Another method is manual, where we put a frame on our endothelial image and we count the cells lying under that frame. So in this method, we can miss out few cells which are present on the borders. So there is another method to overcome this problem, that is variable framing, where the complete cells are, we get a boundary around the complete cells and then those cells will be taken for the analysis. So there are other methods also, like corner analysis, where the corners are identified and then counted. Center analysis, where we put dots over the complete and healthy cells and then take for analysis. Center flex method, where these two methods are combined and automated, as I said, in present in non-contact one. So depending upon these things, important is that endothelial image must be good before analyzing the parameters. So come to the image analysis. There are various machines present in the market, Topcon, Tommy. I have no financial interest. Printout will look different, but all machines will give same parameters and they all are equally important. So this is a printout of a Topcon machine. Here we have many datas in one printout. One is the patient detail, name of patient's age, the date of capture, and then second is the endothelial image, where first one is the raw picture and second one is the traced image. It is done by the machine. And third one is the what type of method of analysis or capture of image has been used. And then this part is very important. Here all quantitative parameters are given in this column. And then the colored image which gives the cell size and cell area present in the endothelium. So in analysis, we can do it by qualitative assessment or we can do quantitative assessment. Quantitative is important. And I'll take first quantitative analysis. So in this chart, first is number, that is written 190. First year resident can say that this is a cell density, but it is not. Number is actually these 190 cells, actually they have been taken for analysis of whole parameters. So second one is the cell density. Here it is 2836, means the number of cells per millimeter square. AVG means this is an average cell area of cells. Standard deviation standard deviation is actually it shows the deviation from the mean cell area. So if it is large, that means there are more variety of cells present. There are large variation in the cell area. Then the CV, this is a coefficient of variation which depends upon the standard deviation. Max and minimum means what is the maximum area of the cells and what is the minimum area of cells. So cell density always take it in terms of the age. Like 89-year-old patient cannot have 3,500 or plus endothelial cells. So if he has 2,000 endothelial cells, that is completely okay. Second is important thing is polymorphism. Here we see this cell area of the cells. If cell area has a lot of variation from the mean cell area, that means the standard deviation is very high, and in that case CV would be rising. And if CV is more than 40 or even 30, then you can consider that there is something happening inside the endothelium, and you should check it with the clinical examination. Similarly, pleomorphism, where the variety of cell sizes are present. Majority cells are hexagonal, and we expect there should be 60% hexagonality must be there to be endothelial cells very healthy. So it's an indicator of wound healing. Now, second is the qualitative analysis, where we see the cell borders, cell shape, intraendothelial structures, interendothelial structures, and we can also see some bright and dark structure that could be normal and that could be abnormal. So bright structure in normal endothelial cells could be cell nucleus, and the dark structures could be endothelial cilia or vacuoles. In abnormal endothelial cells, we can find pigment or KPs as a bright structures and guttae as a dark structures. So these are the pictures, and we just have a look of these endothelial cells qualitatively, and should be correlated with the slit lamp photographs. So this is a case of 20-year-old young male. And if you look at the data, the endothelial picture is totally normal. And if you see the parameters, the corneal thickness is 539, counts 3062, CV is absolutely normal 30, hexagonality is 57. The same patient, other eye, has been operated for healed keratitis. He had PK done 3 years ago and one episode of graft rejection. So here you can see the size of cell is very large. Still the CCT is good, 469. Cell density is just 649, but he's maintaining 6.9 vision with this, because hexagonality is 50% and CV is 27. So this is another, this is the same case, comparison of right and left. You can see the after penetrating keratoplasty, look at the size of cells in grafted cornea in comparison to the normal cornea. So this is one of the very common indication for specular microscopy, that is Fuchs dystrophy. And here we see many dropout areas in printouts. Still the parameters are within normal limits and patient has no complaints. Like CV is 34 and hexagonality is 61, counts at 2898. But as these descemet excrescens, they grow with the time, they actually cause damage to the overlying endothelial cells as well as the adjoining cells. And at this time, patient may start develop some corneal complaints. So this specular microscopy actually helps in imaging the peripheral corneal endothelial health in Fuchs dystrophy. And it is very important in decision making of cataract surgery with or without endothelial keratoplasty. And in these cases, it should be differentiated from pseudoguttata, which usually present in the infection or inflammatory cases where the endothelial cells get swelled. This is a case of macular dystrophy. Here you can see that many dropouts areas are present, and because of the presence of this kind of endothelial cells, now people are preferring doing PK rather than deep lamellar keratoplasty in macular dystrophy. This is a case of posterior polymorphous endothelial dystrophy. Here again we see some dropout area, and we have to correlate this finding with the slit lamp picture, and then only we can make this diagnosis. The very characteristic finding present in eye syndrome, that is dark light reversal pattern. Normally what we see in a specular microscopy, the borders are dark and the center area looks bright. But what happens in the eye syndrome, the borders become light in comparison to the center area, and this is called dark light reversal pattern. In any case where the specular gets some hindrance, like there is, if the cornea has any kind of opacity, haze, then we cannot have a good endothelial image, and here we cannot rely on these findings. The very important indication of specular microscopy in eye banks. So here, if you get a clear, good picture, that means that donor cornea has very good number of endothelial cells. But usually what we get in eye bank setting is specular microscopy, islands of endothelial cells, and we count those islands basically, and then machine gives the number, and it can show many pigments, stress lines, and we decide actually PK or DSEC or DMEC on the basis of endothelial count. So specular microscopy is a simple and very valuable tool for evaluation of corneal endothelium in normal and diseased eyes. But the interpretation of these specular micrographs should be in correlation with the slit lamp findings. Thank you.
So, Rakhi, do you advocate all cataract cases to be taken off for specular before surgery? Or clinical evaluation or specular biomicroscopy is good enough to supplement the informations?
It is not mandatory to do specular microscopy in all the cases, but to learn better things or to anticipate some problems, like you can advise these cases in some particular cases where you are thinking that this case may need some additional procedure, like in cases of pseudo exfoliation or chronic glaucoma cases, or if there is any history of viral keratitis, then these cases this test is mandatory. Otherwise, just for your satisfaction or your type of procedure you are planning for, then you can do this test. There is no harm in doing a specular microscope in all the cases.
I would like to do in those patients who had very hard cataract, brown cataract, and any patient who have undergone cataract surgery with one eye corneal decompensation, then other eye must be evaluated for.
In these cases, it is mandatory.
The last one, the patient with decompensated cornea in one eye, these are the patients who are very crucial.
Exactly.
So thank you, Dr. Rakhi.